We're going to move to talk on fundamentals of angiography. And again, I looked at the content. So there's only 4 bullet points here as to what they want you to know. But the first is the factors associated with angiography, like risks, complications, contraindications. So we'll cover that quickly. And then they want you to know the appropriate positional views to get some of the anatomy identified. And then the third is the normal and the potential abnormal courses of the catheter. So you've seen those questions probably of what's the catheter course here. And then the fourth is the biggest, so interpret patterns of pulmonary and systemic vasculature on angiography, basically anatomy. And those are the questions where they give you an angiogram and they don't ask you what's the diagnosis, they ask you a question about that lesion. So the first thing is you have to recognize what the diagnosis is, and then you have to understand that association. And if you don't know what the diagnosis is, it's, you're stuck, basically. So what we'll do for this talk is we'll go through a bunch of the sort of the classic angiograms that I think they might show you, and then we'll ask what the diagnosis is so we're all on the same page, and then we'll ask about some of the associations. Okay, so I'm just going to run through this first part really fast because I think it's low yield and you can only remember so much. So in terms of the factors associated with angiography, we'll start with contrast. The contrast agent is iodine-based, it's non-ionic, it's isoosmolar, and low in viscosity. Basically, compared to the older forms, it's more expensive, it's lower osmolality, there's less side effects, and we get the same image quality, so a little bit better. And the thing to remember is it's non-ionic and isoosmolar. But the side effects that it does confer are, we get a rise in PA pressure. It causes peripheral vasodilation and resultant hypotension and reflex tachycardia. You probably know that patients get a sensation of heat or sometimes pain or discomfort. It can cause myocardial dysfunction and renal dysfunction. So those are the things to remember. We try to keep the maximum amount of contrast to less than 6 cc's per kilogram. If we go above that, we get side effects that are compounded by poor LV function or renal impairment, or if the patient's really small. And we can see myocardial depression, specifically like if we do a root injection or selective coronary angiography in patients who have coronary artery disease, or in patients who have a supravalvular aortic stenosis, like a Williams syndrome aortopathy. If we do selectives or a root injection, we can also often get a cardiac arrest. And then also in a post-transplant patient, if we take coronary angiography and that patient is rejecting, and we don't really know it because we don't have the biopsy results yet, you can see an arrest in that patient population. So it does cause myocardial depression. It might just be because the contrast isn't carrying oxygen, right? And so if you're infusing contrast and you do it over a long period of time and you really interrupt the delivery of oxygen through the coronary arteries to the myocardium, you can get some significant ischemia. When we inject, we can get air emboli, myocardial staining if the catheter is right up against the myocardium, or even vessel dissection. So radiation. Angiography involves radiation, and I think the thing to remember, so risk is dependent on exposure. The recording modes like Cine give much more radiation than just fluoroscopy, and that's why we do a lot of image saving rather than Cine these days. The thing they might question you on is the most common side effect of radiation is transient dermal erythema. and others are potential, but that's the most common. And then in terms of the timing, it might not present for hours or even months after the exposure. You might get a story of a kid who went through a catheterization, a long catheterization, had a lot of coils placed or something like that. And then a couple weeks later, his mom calls and he has some changes on his skin, some red or dark areas of his skin. That would be transient dermal erythema. So moving from that to the camera angles. So I think the best way to approach the camera angles is just to think about the anatomy that's represented on a 2D echo. And then if you just start with that, then apply the principle that in general we try to position the cameras perpendicular to the structure we're trying to look at so that we're avoiding foreshortening or lengthening. So if you just sort of can visualize the anatomy when you're looking at just this X-ray. Straight PA and lateral is this configuration. And so this is an RV angiogram in straight PA and lateral. Now, if you want to look at the pulmonary valve, okay, if you want to look at the pulmonary valve to get a measurement, you can see when you look at the PA angiogram that the RV outflow tract in MPA just basically goes straight back, so from anterior to posterior. So if it's going straight back, then a straight lateral is perpendicular to it. And that's why when you look at the straight lateral, the pulmonary valve looks perfect here. I mean, you can really tell the anatomy of the pulmonary valve and get a good annular measurement. But you can't when you're looking this way because you're basically looking down the barrel of it. And you can confirm that by looking at the lateral. If the PA camera is looking in this direction, then you're looking down the barrel of the pulmonary valve. So if you want to go perpendicular to it, with your PA camera, then you're going to take your PA camera and go cranial so that you can look straight down, and that's what this will look like. This is a cranial view showing the pulmonary valve. So I guess what I'm saying is look at your, I'll show you this. So you take your PA camera that's coming straight down, move it cranial, and that's what this looks like. And that's what the picture would look like. So looking between your PA and lateral to see, okay, how can I get the best perpendicular view? So here's another example. Now you want to look at the proximal branch pulmonary arteries, okay, which you can't really see them beautifully here. You want to see the bifurcation coming off the MPA. Well, that's over here, right? This is the RV outflow tract, pulmonary valve, main pulmonary artery, and the two branch PAs here. So how are you going to do that? You can't bring the camera, the PA camera, so far cranial that it'll go perpendicular because you'll be looking through the head. But you can bring it caudal so that it's perpendicular. And so that's what you would do. You would bring it caudal, and then you can really lay out these pulmonary arteries, and so that's bringing this PA camera toward the feet. So those are the ways you manipulate cranial or caudal and the reasons you would. So then in terms of camera angles of your PA camera going to the right or to the left, so we call them right anterior oblique when we go from straight PA to the right, or left anterior oblique when we go from straight PA down to the left. So this is the, let's see, let me just move to the ascending aorta. So if we want to look at the aorta, and we want to get a perpendicular view of this arch, when we look at the PA view, we can see that the ascending aorta is almost overlying the descending aorta, but it's just a little bit to the right. So the ascending is just a little bit rightward to the descending. So if we want the lateral camera to go perpendicular, we don't have to bring it very far up to be perpendicular to that, right? So if we want this laid out view of this, we just go a little bit from 90 degrees maybe to 70 degrees. Now in this arch, the ascending aorta is further over to the right, so it's not overlying, it's further over, so you're going to just keep bringing that lateral camera more LAO. And then and you'll get something like this. And then this one is, is just the furthest example. So the further over this structure gets, the more LAO you have to bring it. In terms of left anterior oblique, it's good for aortic arch. It also is good for proximal LPA, because remember the LPA comes off and goes leftward and posterior. So if we want perpendicular to that, we're going to go LAO. And then left pulmonary veins, because they come in from posterior to anterior, but sort of coming from left towards the midline. Right anterior oblique is bringing the PA camera towards the right. And that is when we have a structure that's sort of coursing in this direction, passing from anterior to posterior and rightward, so coming out at you and going rightward. If we bring the PA camera over towards the right, we can get perpendicular to that. So right anterior oblique is really good for the left ventricular outflow tract, when you look for subaortic stenosis or the aortic valve annulus, or to see the gooseneck deformity in AV canal. And then anterior muscular or outlet VSDs are also well seen here. Long axial oblique, so not left anterior oblique, but long axial oblique is the combination of left anterior oblique plus cranial. And so if you want to sort of look at the aortic valve, for instance, you would bring the camera up towards the head and LAO as well. And so this is what that would look like. And here you can see it really nicely lays out the aortic valve, the subaortic region, and the supravalvular region. So this is what it looks like. It's cranial and LAO, and it's good, and this is RAO. This is cranial LAO, and it's good for LV outflow tracts, the annulus, like I said, and then the membranous conoventricular anterior midmuscular VSDs. So it's similar to a parasternal long axis view on echo. And then the last one is this hepatoclavicular view. That's when you go it's basically 45 degrees left anterior oblique. So if this is 0 and this is 90, it's basically halfway between them, and then you go 45 degrees or pretty far cranial, and that gives you a nice view of the atrioventricular valve anatomy, so inlet VSDs, basically the crux of the heart. If you wanted to see an LV to RA shunt, or any of those areas of the endocardial cushion, that's the view for it. Okay. So catheter course, we'll do a few questions on these, but just to make sure everybody's on the same page. So we're all looking at the X-ray of the heart when we're doing our caths. So I know this is basic, but just to get everybody on the same page, because I know some of you haven't been in the cath lab in a while. So the catheter comes up, this is typical normal catheter course. So if you see this, IVC to RA, and then further up is going to be the SVC. If we find ourselves leftward, we're in the innominate vein. What might this be? Yeah, it's pulmonary vein. So azygos, I'll show you in a minute. That's not a bad guess, but it's too far into the lung. But if there's a partial anomalous pulmonary vein coming in, or a pulmonary vein coming in, that's where your catheter would end up. What's this? That's the azygos, right? So, but it depends on what it looks like on the lateral view, okay? Because if this is really posterior and then this is anterior, what is this? So if you look on the lateral, and this is really posterior all the way, and then it comes anterior, that's an interrupted IVC with azygos continuation, and then you came into the azygos, the SVC, and in the RA. Okay, so if it's coming along the spine and then ends up anterior, that's an interrupted IVC, coming up the azygos and entering the SVC and RA. If on the lateral, this is more anterior and then this goes posterior, then you went up the IVC, RA, SVC, and then you went into the azygos and went down the azygos. So the azygos is posterior to the right atrium, is the bottom line, okay? So, okay, so now what could this be? It's hard to know on a PA only, so you'd have to look at your lateral. So let's say the catheter keeps going and now you're there. Yeah, pulmonary veins, right? So that's what your catheter course would look like. If you end up in the lung, you most likely went across an atrial septal defect into the LA and then found your way into a pulmonary vein. So otherwise you go up IVC RA, now you're going to the right ventricle and out the outflow tract. And so that would be now you're in the lung again, but you can see this is a catheter course through the MPA and into the branch PAs rather than the pulmonary veins. Where's that? So how could you get from the MPA down to what looks like the aorta? Exactly. So through a ductus, which would be up there, and then down to the left side of the spine, which would be the descending aorta. Okay, and then this is going up the left side of the spine and around. So what does that look like? A left aortic arch. Good. And then to the left ventricle. And again, you would want to see that you're in a left-sided posterior ventricle, and you'd only know that on the lateral view. Where is that going? So if it's a left arch, it's going up into one of the brachiocephalics, so the right subclavian artery, and that's a little bit off. I would expect this to go a little bit higher, and then down and into the lung. So that would be through a BT shunt. If you get into lung from the arch, think about how could that happen? Well, through a ductus into a PA or through a BT shunt into a PA. And then here, if you're up the aorta and then you suddenly come down here and you're really anterior on the lateral, what'd you say? Lima? Yeah, it's the left internal mammary. It's really anterior on the lateral, but this is where the lima is. This is where the rima is. Okay. And then if you're coming from above, so right IJ, SVC, where does this look like to you? Yeah, it's too high for the PA. The PA would be down here, so that's the innominate. And if your catheter then goes this way, you're in the lung now, where are you? That's the pulmonary artery, so either you have a Glenn or a Fontan, or you had a partial anomalous pulmonary venous return and you're in the pulmonary vein. But they would give you some clues. This is typically RPA post-Glenn, and this is LPA post-Glenn. I think I did one. Okay, this might be a reasonable one where they would test. So SVC, innominate vein, and then now where are you? LSVC, right? LSVC to where? Where could it go? Coronary sinus, right? Or to the LA. Good. And then this is one that is a classic course. Okay, it's not Fontan. That's not a bad guess, actually, because that could be like a lateral tunnel Fontan. But this is classic for what else? It's adult congenital mustard, exactly. So remember how she said you put the pant leg here, and you bring it over, and the waist goes over to the mitral valve? It really is, like when you're trying to cath a person with a mustard, you don't go straight up. You go this way, and then it curves over this way, and then you have to have a wire or something to help you get back this way and go up the SVC. So this is what it looks like for a mustard. And this is the systemic venous baffle. And then the other thing they show you is getting out to the pulmonary artery. So if you have detransposition post-mustard and you want to cath that person and go out to the pulmonary artery, show me your course. You're going to go IVC to systemic venous baffle, right? And then what valve do you cross? The mitral valve to go to the LV, right, which is the pulmonary ventricle. And then you go, so the left ventricle is in the normal position in a detransposition who had a mustard. So it's systemic venous baffle to the left ventricle, which is leftward and posterior, and then your pulmonary artery is over here leftward, and then, your pulmonary valve and main pulmonary artery, and then your PA. So that's a kind of a typical one. Yeah. Okay. So now we're going to go to ARS. So grab your thing, and we're going to just show you some questions with angiograms. Okay. So which of the following is true regarding transcatheter closure of the lesion shown? I'll show you the options in the next picture, but I didn't know if the movies would work with ARS, so I separated them. So just take a second to see what lesion we're looking at here. And, it's going forward and backward, sorry. So you see the lesion? Now let's go to the next slide. I've still framed it there, and in this particular question, all of the options confirm what the lesion is. So you didn't, but in many of them they won't. But this one, just to warm you up a little bit. Okay, so your options are: a small audible PDA is a class 1 indication for closure. A PDA associated with a right to left shunt and pulmonary hypertension should always be closed. Aspirin is not indicated after coil or device closure. Aspirin is indicated for 6 months after device closure, or SBE prophylaxis is indicated indefinitely after device closure. Excellent. So the answer is C. And aspirin is not indicated after coil or device closure of these. Some of you chose D. Remember, for ASD devices, we use aspirin for 6 months, but for ductuses, we don't anticoagulate after device closure. So we do SBE prophylaxis for 6 months, but not anticoagulation. And then A, the class 1 indication for closure is a moderate, at least moderate, so moderate or larger audible PDA is a class 1 indication for closure. A small one is a class 2. Actually, I think if you go to the next slide, I think I kind of explained things on the next slide, so we'll remember to do that. But if you also want to just look at why certain answers were incorrect and I didn't go over it, then there's that should be in your syllabus as well. Okay, so the next question. All right, don't vote until the next slide because I'm just going to show you the movie here. So go ahead and run the movie. The lesion showed on the angiogram may be associated with... Okay, so here's the lesion. This is a more typical question. It won't ask you what it is, but it'll show it to you and then ask for. So let's go to the next slide. Okay, so here's a still frame of it. Use your clickers now and vote on. Good, so most of you got that right. And the first order is, did you get the angiogram or the diagnosis right? So what did you think about this? What was this angiogram? This was the left ventricle. You can see the aortic arch right there. So the left ventricle, you can see the aortic valve and then this small supravalvular aortic stenosis coming around. And so this was Williams syndrome. which is 7q11 microdeletion. It's associated with supravalvular aortic stenosis, but also PPS, and I told you that we don't dilate Williams syndrome very well when they have peripheral pulmonary stenosis. PTPN is associated with Noonan syndrome, that's pulmonary stenosis and hypertrophic cardiomyopathy. The JAG mutation is Alagille, and that's associated with PPS and tetralogy of Fallot. 22q11 is DeGeorge, so interrupted aortic arches, truncus, right aortic arch, tetralogy of Fallot, or the conotruncal VSDs, and then the Ellis Van Creveld mutation, ASDs and common atrium. Okay, so what is the lesion depicted in this angiogram? So obviously there's no question, or there's no options yet, so just take a look at this for a little while, and then we'll go to the next where I've still framed it for you. Okay, so what is the lesion in this angio? Pulmonary atresia with VSD, hypoplastic left heart syndrome, severe Kawasaki, pulmonary atresia with intact ventricular septum, or double inlet single ventricle with bulboventricular foramen and hypoplastic RV. Okay, excellent. That one, you guys nailed it. So that's pulmonary atresia with an intact ventricular septum. I would just say, pay attention. Like you read an x-ray, you sort of, look at everything. So look at this catheter course. It's coming up the right side. So that's probably the inferior vena cava going to the right atrium. And then it crosses this tiny tricuspid valve into this little chamber that then fills, and you see what look like coronary arteries. So that's a typical classic angiogram of PA-IVS. Now, this is the sort of way the test will go. It'll give you that angiogram, and then it'll give you a series of questions. So which of the following statements is true regarding the lesion shown? Pulmonary arteries are discontinuous in more than 40% of patients. The tricuspid valve size is an important factor in determining the potential of a two-ventricle repair. An Epstein-like tricuspid valve deformity is a common variant associated with a good prognosis. Most patients require a balloon atrial septostomy after birth. Or E, the presence of RV-dependent coronary circulation is a class 2B indication for pulmonary valvuloplasty. Great, perfect. So this is exactly right. The tricuspid valve is an important factor in determining whether or not you can treat this ventricle or whether or not this ventricle will participate in a two-ventricular circulation. So the first is not correct because discontinuous PAs are a feature of pulmonary atresia with a VSD, not pulmonary atresia with intact ventricular septum. An Epstein-like tricuspid valve would confer a very poor prognosis. You'd have a bigger RV because flow would be going back and forth, and you'd have a huge RA, but it would be a poor prognosis. And then BAS isn't required in this. In utero, they would have had a large ASD typically. And then finally, the presence of RV-dependent coronary circulation is a class 3 indication. In other words, it should not be done. Same patient, what is the next likely surgery for an infant with this lesion? Transcatheter perforation and dilation of the pulmonary valve, pulmonary artery unifocalization, and surgical transannular patch. Stage 1 with sono, stage 1 with right modified BT shunt, or a right modified Blalock-Taussig shunt. Okay, yes, the answer is a right modified Blalock-Taussig shunt. And so if you think about this, well, not many answered A, B, or C, but as we talked about, we're not going to perforate this valve because of the RV-dependent coronary circulation, but really, I don't know if those are dependent or not, and you wouldn't have the time probably to, or the angiogram wouldn't be a good enough quality on the exam for you to determine whether those coronary arteries were dependent on the RV, because you have to have stenoses in the pathway. So you don't know for sure, but just looking at this tricuspid valve is tiny and the RV is too small, so we're not going to turn this into a ventricle that participates. In terms of the B, as we said, the pulmonary arteries are usually continuous. And then stage 1 with sono. So both C and D, this patient has a good LV, it's been getting good flow in utero because flow isn't going to the RV, so blood's been going through the LA, LV, ascending aorta, around the arch, and down to the placenta, to the rest of the body and the placenta. And then there's been ductal flow to the pulmonary arteries. So this baby doesn't have any problems with their arch. They don't need stage 1 Damas K. Stanzel and arch repair for pulmonary atresia. They just need a stable source of pulmonary blood flow, so they need a ductus or right modified BT shunt. All right, what lesion is depicted in this angiogram? All right, it's very distracting that it's going kind of dissociated. So I'm going to go to the next one, which is a still frame of it, okay? So which lesion is depicted in this angio? Tetralogy of flow with absent pulmonary valve, tricuspid atresia, pulmonary atresia with intact ventricular septum, or pulmonary atresia with VSD, or interrupted aortic arch type B. Okay, so the majority of you got this right. It's pulmonary atresia with VSDs. And so what we're looking at is the catheter coming up the left side of the spine and then coming up and around. So that's the aortic arch. It's a left-sided aortic arch, and you see the brachiocephalix coming off in the PA view. But then you see by injecting in the aorta, we're seeing pulmonary arteries. We're seeing pulmonary arteries on the right, and then in that descending aorta, we're seeing a vessel coming off and feeding pulmonary arteries. So these are aortopulmonary collaterals arising from the aorta. And we don't, so the correct answer was pulmonary atresia with VSD. That's where we classically see this. And the pulmonary atresia is typically a lung segment, and we can either have discontinuous or continuous pulmonary arteries. But if we have something like this where there's so many collaterals, we often have discontinuous pulmonary arteries or just tiny central PAs.
See that lesion in the pulmonary atresia in that ventricular septum?
Very, very rarely, if at all. No, we don't. It depends on when the pulmonary atresia developed and whether there was flow, but the classic angiogram there, that's from pulmonary atresia with a VSD, so you'll have the potential for repair, or maybe I get to that, so I won't go through it. So which of the following is correct regarding the lesion in this angio? So the same patient, PGE is necessary for all newborns with this lesion prior to surgery. Preoperative cardiac catheterization is indicated to determine the pulmonary artery anatomy and the sources of pulmonary blood flow. C, all aortopulmonary collaterals must be coil occluded prior to surgical repair. D, right aortic arch is rarely seen with this lesion. Or E, subsequent procedures following surgical repair of this lesion are seldom necessary. Which of the following is correct? So you chose preoperative, and that's exactly right. So the typical way of treating these patients is first to identify all of the sources of pulmonary blood flow and make sure we understand those before proceeding. In terms of the incorrect answers, prostaglandins, you may know from your clinical experience that some of these patients have so many aortopulmonary collaterals, they really don't need the ductus, and some don't even have a ductus providing additional pulmonary blood flow. So you have to do B first and determine whether the ductus is important or not, but sometimes you just stop the prostaglandins or never start them, and the patient can go home for a period of time before the surgery is performed because they have fairly stable sources of pulmonary blood flow. In terms of C, if there's dual supply to a portion of the lung, we can coil one of the sources of supply, but what we're going to do is unifocalize all of those sources, especially those that are major or single sources. Right aortic arch is actually, this is something to remember. They like to sort of bring these associations into play. So the right aortic arch is seen more often in tetralogy of flow with pulmonary atresia, or some people call it pulmonary atresia VSD, than any other form of tetralogy of flow. And then subsequent procedures following the unifocalization of this unifocalization procedure is really common. So typically pulmonary angioplasty or stenting, and then of course they have an RV to PA conduit, so that needs to be changed out. So all of those things need to occur. All right, which of the following statements regarding this type of surgical repair is correct? So they do test you. They want you to recognize when surgery has been performed and what the repair has been. So this is a little bit tricky. I'm going to give you a hint. It's a single ventricle patient. Okay, so your options are the right modified BT shunt may be coil occluded at a later cath. The surgery is associated with increased risk of coronary insufficiency, associated with increased risk of retrograde coarctation, associated with increased risk of pulmonary artery stenosis, or associated with increased risk of LV outflow obstruction. Okay, so the correct answer is D. So first of all, what does this show? So the catheter is coming up from the right side. It looks like it's coming up the IVC into the RA, RV, and then through something that's pretty uniform and small in diameter that is really anterior and then connects into the pulmonary arteries. Okay, so what is this showing? So it is showing a sono. It is showing an RV to PA conduit. Okay, how many of your programs do sonos? Okay, so your angiograms probably look different depending on how the surgeon does the sono, right? So that's a fair point. This is a sono at our institution, or one of the sonos at our institution. So you see this conduit basically that's going from the RV to the PA. So that's in a single ventricle, you can say, okay, this was a sono. So now if you know that it's a sono, option A, BT shunt may be coil occluded. So I would say this isn't a BT shunt because a BT shunt would be coming straight down on the lateral from the SVC down to the PAs. So the lateral view, it wouldn't be anterior to posterior. And your catheter course to get to a BT shunt, I guess you could go RA, RV into the aorta and then into the subclavian artery and down, but that's not the catheter course that's shown here. So that wouldn't be a BT shunt. Now the questions are, is a sono associated with increased risk of coronary insufficiency? No, right? The BT shunt is thought to be associated with increased risk of coronary if insufficiency. So if you know this is sono, you would say no. Is it associated with increased risk of retrograde coarctation? Not the sono, the ductal stent in a hybrid procedure, but not the sono. And then D, is it associated with increased risk of PA stenosis? The answer, that's the answer. The surgeons, as they insert this conduit on the PAs, sometimes distort them, and LPA stenosis, at least in the early days, was pretty common. And then associated with increased risk of LV outflow obstruction. No, this is a baby typically with a hypoplastic left heart syndrome, and that's not an association, which none of you chose, which is great. So, okay. The angiogram here demonstrates which of the following surgical procedures. So I'll let that show, and then I'll show you the still frame. Okay. A right modified BT shunt, a classic Glenn, a bilateral bidirectional cavopulmonary anastomosis, a bidirectional cavopulmonary anastomosis, or a fenestrated lateral tunnel Fontan. Oh, excellent. Yeah. So it's a bidirectional cavopulmonary anastomosis. So a right modified BT shunt, I guess you could say, oh, the catheter is coming in through the carotid artery, but that would be so unusual, and they wouldn't show you something like that. So this is not a shunt, just based on the catheter course. So a classic Glenn, remember, connects the right SVC to the RPA, and usually the LPA is disconnected from the RPA. So the RV continues to provide flow to the LPA. So you see that LPA stenosis, and that might have triggered that, but this is a typical bidirectional cavopulmonary anastomosis. I might have chosen C if I was in a hurry, because I see that basically that's a Glenn, and I wouldn't have read the whole options, and I wouldn't have recognized that said bilateral bidirectional Glenn. So a couple of you chose that, and be careful. And you might have thought there was a wash-in coming from a second SVC, but they're not going to be that tricky, okay? And if you really looked at the angiogram, you would see there was no wash-in of non-contrast flow coming in. It's just a narrowed LPA. And then I don't think people chose E. So same angiogram, which of the following statements is most accurate? An LPA stent placement should only be considered in patients in whom the stent can be dilated to an adult size, except in extreme situations. B, LPA stent placement may be considered for a pulmonary artery gradient more than 20. An LPA stent placement can be performed from the femoral venous approach. LPA stent placement should never be considered for this lesion. Awesome. Okay, so the answer is A, LPA stent placement. This is a good answer. This is always going to be true if you have this as an option, because they want to drill that down to you. But let's look at B, because 20% of you chose that. LPA stent placement may be considered for a PA gradient more than 20. So yes, that is the class 1 gradient that they mention. But in a Glenn patient, remember the SVC pressure is going to hopefully be 14 or 16. So you're not going to have a gradient of 20 in a Glenn. In fact, in this patient, probably with that level of stenosis, you have a gradient of maybe 2 or 3 millimeters of mercury. And because of the lack of phasic, you're not going to have a systolic gradient. It's just going to be a mean gradient. So we don't need a high gradient to stent this. We want to look and say, is the left lung getting as much flow as the right lung? Probably not in this, because there's this PA stenosis. If I put a stent in there, can I augment the flow going to the left lung and therefore set this patient up as a better candidate for the Fontan? So that's why you would stent this, and you don't need a gradient of 20 to proceed. Okay, so don't vote on this. Just take a look at this and look at the options. The straight PA angiogram below demonstrates which lesion? Tricuspid valve stenosis, subaortic stenosis, SVC stenosis following a Warden procedure, pulmonary venous baffle obstruction following a mustard, or systemic venous baffle following a mustard. So there's the angiogram. Just look at it one more time here, and then I'll go to the next slide, and you can vote. Okay, so here's the still frame of that. Go ahead and select your option. Okay, awesome. Yeah, so that the answer is E. So this is a picture of systemic venous baffle obstruction following a mustard operation. So if you look at this picture, you see the catheter is coming up from below, and then it goes towards the patient's left, and then back towards the patient's right. And as it goes back towards the patient's right, there's a decrease in the diameter of the structure. So the SVC is what's darkest there, and that's big, and then it narrows down as the contrast goes into that chamber. So if it was tricuspid valve stenosis, if that narrowing was the tricuspid valve, where's the right atrium? Because the right atrium should be above the tricuspid valve, and that's not big enough for a right atrium, so that's not it. Subaortic stenosis, just by the catheter course, we should know we're coming up the IVC, not coming up and integrate through an aortic valve. The SVC, some chose SVC stenosis following a Warden procedure. The right atrium is way too far leftward, because that would be a normal right atrium. So for this one, the clue is that this right atrium is way over leftward, and that makes it a systemic venous baffle. And then those of you who chose D, remember the pulmonary venous baffle is what connects the pulmonary veins to the right ventricle. This is the classic picture of an SVC angiogram in a patient with a mustard. So you see SVC, the systemic venous baffle, and if you watch the angiogram, you would see the contrast went to the pulmonary arteries. So that was a clue that it was, following the normal pathway through a mustard. All right, next question. A 3-year-old with an unbalanced AV canal, status post a bidirectional Glenn, presents with increasing cyanosis. The SVC angiogram identifies the most likely cause to be what? So here's your angiogram. And here are your options. Left pulmonary vein stenosis, multiple venous decompressing collaterals, left pulmonary arteriovenous malformations, multiple left aortopulmonary collaterals, or severe stenosis of the cavopulmonary anastomosis. Do you need to see it again? Okay, so here's the angiogram. Sorry, I didn't put them on the same. So was it a severe stenosis of the Glenn, a decompressing collateral from the SVC or innominate vein, multiple aortopulmonary collaterals, or pulmonary AVM? What would make her blue? Okay, so here's select your answer now. C, left pulmonary, yeah, that's the correct answer, is left pulmonary AVM. So going back to this, so you have an SVC angiogram. Basically, you see most of the flow goes to the left lung. You see the pulmonary arteries there, and they look really abnormal, and then you immediately see pulmonary venous return. So this is a classic picture of pulmonary arteriovenous malformations. This child has lost the normal circulation that goes from artery, arteriole, capillary, venule, and then vein. And so these big vessels, arteriovenous malformations, just connect the artery to the vein. There's rapid flow from the artery to the vein to the common atrium, and that lung is not picking up oxygen or putting oxygen into the circulation. And so the patient will present by being blue. You can also see she's a setup for that because without hepatic factor going through the lungs as a first pass, she's at risk for these. So she's a 3-year-old post-Glenn, and so she's at risk for pulmonary AVMs. We don't see any decompressing veins on this. We don't see a stenosis of the Glenn. It doesn't show. And then aortopulmonary collaterals, we would see wash-in. I don't know if you thought maybe you were seeing that on the right side, but what you're seeing is flow going to the left because the resistance to the pulmonary vascular resistance is so low because of these pulmonary AVMs that it just draws all the flow there. But we don't see pulmonary or aortopulmonary collaterals, and that wouldn't be a reason to be blue. It'd be a reason to have high Glenn pressures, but not a reason to be blue. So the bottom line is, get that image. If you didn't get that question right, get that image in your mind that that's what pulmonary AVMs look like, and that would be the scenario that you would see it in, okay? All right, now this is another classic angio of a rare condition that you should get to know. So this is, it doesn't ask you what it is, it asks you all but which of the following are typical features of the lesions shown on these angiograms. So the first thing is figure out what you're looking at first. So I'll walk you through it a little bit. So the angiogram on the left is the catheter's going up the aorta, and you're taking a picture in the aorta, and the angiogram on the right, the catheter's coming up the right side of the spine in the IVC and going from the IVC going into the lung. Does that help? Yeah, okay, and now I'm going to give you the choices. So there's the still frame. So all but which of the following are typical features of the lesion shown? Right lung hypoplasia, dextro or mesocardia, aortopulmonary collaterals to the right lung, a right aortic arch, or drainage of the right pulmonary veins to the IVC. And the answer is D. So most of you got that right. That's excellent. So what is this? Good. So that's first step. This will be the angiogram you see, or some angiograms you see. So the aorta shows aortopulmonary collaterals, which are a feature of scimitar syndrome. So you have sometimes you have a segmented portion, or sequestered portion of the right lung in particular, and you have an aortopulmonary collateral that's supplying flow to that. And you can see on the angiogram to the right, that's been coiled off by the time they took that angiogram. So this is scimitar, and it's associated with right lung hypoplasia. The heart then moves over towards the right side of the chest because of that as a secondary phenomenon. It's associated, as I said, with APCs to the right lung. And then the drainage of the right pulmonary veins via the scimitar vein is to the IVC. So that's part of it. Right aortic arch is not part of it. RPA stenosis and an ASD are the other two features that are associated with scimitar. Okay, all of the following statements about this disorder are correct except A, presentation during late adolescence or adulthood may not require surgery. B, they may present in infancy with tachypnea and RV hypertension. C, post-op pulmonary vein obstruction is more common following surgery in infancy than adulthood. D, transcatheter treatment includes coil occlusion of APCs. And E, transcatheter treatment includes coil occlusion of pulmonary AVMs. Okay, and the answer is, surprisingly, the answer is not A. So, I always assumed they would need surgery as well, but if you've gotten to late adolescence or adulthood and haven't required surgery, many of those patients are going to be fine and they don't require repair. So that's not correct, or that's a correct statement, A. The answer is E. I'm sorry. The answer, the answer is E. You got that right. Transcatheter treatment doesn't include coil occlusion of pulmonary AVMs. Sorry about that. And in fact, Antonio and Chris say that they don't write questions like this where they say all is true except. But I was trying to pack in as much sort of teaching in these questions so that you could review them as possible. So all of the A through D are all true statements about scimitar syndrome, and E is not a true statement. And this is the explanation for those. All right. Can you what?
What is the typical course of repair for someone with scimitar?
If they need to, then they connect the scimitar vein to the left atrium so that it's not a left to right shunt. And then also typically leave the RPA alone. But if there's significant pulmonary hypertension, then either you do a transcatheter occlusion of that APC or somehow remove that sequestered portion of the right lung that's promoting pulmonary hypertension to the whole system. And as I said in that question, let's see, number C, or letter C, post-op pulmonary vein obstruction, where that baffle has occurred, is more common following surgery in infancy than in adulthood. And it's just that I think of it as the structures are so much smaller, and as they have to baffle it over to the LA, if you're doing that in a newborn or a small baby, you end up with stenosis more often than if you're doing it in an adult. Okay. So an 18-month-old girl, recently adopted from China, presents with severe cyanosis and failure to thrive. Medical records aren't available, but you're told she had a bidirectional Glenn while in China. What structure is demonstrated in the angiogram? So that's the still frame of that. And is it a right aortic arch, a vein of Galen, an azygous vein, APC, or partial anomalous pulmonary venous return? So you have your catheter coming in from above, like in a typical patient with a Glenn. That makes sense. And it's probably going into the SVC, and you've injected in the SVC, and you see this structure coming off the SVC. And she's blue. And the answer is C, exactly. So this is an azygous vein. I showed this because also you get this question in catheter courses. But again, so the azygous vein comes off the SVC, and should it be there after a Glenn? Absolutely not, right? So you've basically separated the SVC from the right atrium in the Glenn and sewed it to the pulmonary arteries. If you leave the azygous, you've left a connection from the SVC to the IVC, which goes to the RA. So you've left a connection from SVC to RA, which the surgeons just separated. So part of the Glenn is to separate the SVC from the RA, but also to ligate the azygous vein. So whether or not they did this in China and it just didn't, the tie came off, or whether they didn't do this, we don't know. But this girl was super blue. The blood that was supposed to go to her pulmonary arteries was going down the azygous and back into her heart and off to the systemic circulation. And if you saw the angiograms, you could see that there was some blood going into the pulmonary artery from the SVC. So you confirmed that it was a Glenn operation, but there was just this huge decompressing azygous vein. And that's what the azygous looks like.
You have a interrupted IVC and this is going.
Yeah, if she had an interrupted IVC, then that's what the azygous continuation would look like going into the SVC. But she didn't. Yeah. The scenario makes sense if she's super blue and she had a Glenn and you inject and it's going downward, yeah. Okay, so an 8-month-old presents with fussiness, poor feeding, tachycardia, ST changes, and normal SATs. He's taken to the cath lab where this angiogram is performed. What is the diagnosis? So pay attention to the catheter course, where the catheter is that you're injecting, and then what you see. Okay, and your options. So is this severe left pulmonary artery hypoplasia? Is this Al Kappa? Is this left coronary artery fistula to the pulmonary artery, a coronary sinus atresia, or untreated Kawasaki? You want it again? Okay. Where's that catheter? It's in the aorta, coming up the aorta and around, so you're injecting from the aorta, right? Okay. All right. So the answer here is C, and those of you who chose B, so the truth is that you have a left coronary artery connecting to the pulmonary artery. The way you knew it was C and not B is that Al Kappa, which the scenario sounded like, right? It sounds like this kid is got Al Kappa, the typical presentation of Al Kappa. But remember, Al Kappa is that then the left coronary artery arises from the pulmonary artery. So if we were seeing this angiogram of a left coronary artery, and we're seeing the pulmonary artery in the same picture, then it could be Al Kappa, but it would be an angiogram in the pulmonary artery, because the left coronary is coming off of the pulmonary artery. It doesn't come off of the aortic root. That's the whole point. And so if you have the catheter in the aortic root taking a picture and you see the left coronary artery, it's not Al Kappa. What it is it's a left coronary artery fistula to the pulmonary artery. So in other words, you took a picture in the left coronary sinus and you saw the left coronary artery, and then you saw the pulmonary artery. So that's a left coronary artery fistula to the pulmonary artery. Does that make sense? It's a little tricky, I guess, but just if you really understand anomalous left coronary artery from the pulmonary artery, you'd realize that if you were in the aorta and you took a selective in the left coronary sinus, there would be no left coronary artery, right? What is the anatomy demonstrated in this still frame angiogram? Bidirectional Glenn, stage 1 Norwood with a sono, hybrid procedure with a ductal stent and PA banding, stage 1 Norwood with a BT shunt, or unrepaired truncus arteriosus. Okay, so this was tough for people. The answer is stage 1 Norwood with a BT shunt. So let's look at it. So you're injecting in the aorta because you've got this catheter that you see, especially in the lateral view, coming up from the back and then going forward. So you're injecting, and what you see is an ascending aorta. This right here is your biggest clue. This is the native aorta. This is the neo-aorta. So this is a Damas case stanzel. And so you know you had a stage 1, so it's either going to be B or D. And then you don't see any sign of a sono, and in fact, you wouldn't see the PAs from this injection if it was a sono, right? The only way to see the pulmonary arteries, which you see over here, from an aortic injection is with the BT shunt. Okay, so I think the takeaway here, even though this question was obviously confusing a little bit to people, the takeaway is this is a classic angiogram of a Damas case stanzel with the native ascending aorta and the neo-ascending aorta. And if you take an angiogram with a DKS and you see the PAs, you haven't gone to the Glenn yet. You still have a connection from aorta to pulmonary arteries, and that's via the stage 1, the BT shunt. Let's see. So same angio, the patient presented with hypoxemia and poor feeding. What diagnosis made by this angiogram to explain these symptoms? let's go through this quickly because this isn't a very good picture of it. Your options are LPA stenosis, occlusion of the right subclavian artery, right lower lobe pneumonia, severe aortic stenosis, or stenosis of the BT shunt. Let's just move through it. It's stenosis of the BT shunt, and I'm moving through it quickly because it's not a great picture when it's projected like this. Hopefully you'll get better pictures, but it is a stenosis of the BT shunt, and if you could see a better picture of it, you'd see it. Okay, so this isn't an angiogram, but I thought it was a good image to show and ask a question about. The lesion pictured is associated with all of the following except. So first of all, take a look at this lesion. It's a CT, and you can see the airway in pink or salmon, and you can see the heart structures and circulatory system in the white or gray. The airway is this pink structure. And then the options are an abnormality in development of the sixth aortic arch, complete cartilaginous tracheal rings, posterior indentation of the esophagus, respiratory symptoms are more common than dysphagia, or the ligamentum ductus arteriosum connects the descending aorta to the MPA leftward of the trachea, which is wrong. All right, this is a mixed bag. So, so what is this? It's an LPA sling, yeah, right? And it's got this airway issues as well that's commonly associated. But this is an LPA sling, and you can see it from the posterior view best, where the LPA wraps around. So this is associated with regression of the left sixth arch. Cartilaginous rings are seen in more than 50% of slings. The esophagus is typically not obstructed. It's more the airway issue. And then E, the ligamentum, this is the appropriate anatomy, and I'll show you a picture. C is not correct because the LPA travels anterior to the esophagus, between the esophagus and airway. So there's an anterior esophageal indentation, not a posterior. Posterior indentation would be in a vascular ring. Anterior would be in a sling. And I just showed this picture because this is where that ligamentum arteriosus is in an LPA sling. You can see the ligamentum there, which is leftward, and that can create even further constriction. So we're going to stop here.